Postpartum hemorrhage is excessive bleeding after a mother gives birth. It's one of the major causes of maternal mortality. Its worldwide prevalence is 6%. In Kenya alone, 34% of maternal mortality is secondary to postpartum hemorrhage. Now, that is what we are discussing today at Imara MedPlus Hospital in Embu, where we are privileged to have Dr. Mokua. Hi, Daktari.
Salama sana.
How are you?
I'm good.
It's a pleasure having you in our show.
It's also a pleasure having you around. Thank you for bringing your team. I've actually been following up with your show, and I think you're doing a fantastic job.
Thank you.
Yeah.
We are happy.
Very true.
Please tell us something about Imara MediPlus.
Imara MediPlus Hospital is an outpatient facility based in Embu.
Okay.
Its main purpose is to provide holistic services, holistic outpatient services to our people of Embu and also its environs. When I say its environs, it includes the outskirts of Embu. That includes Runyenjes, Siakago, Kiritiri, and Ishiara.
Okay.
We have all those people coming to access services here. So the main services being provided at Imara MediPlus Hospital include the basic consultation services, and you're guaranteed being seen by a medical officer in this facility. Qualified medical officer. Right. We also have lab services. We do various types of investigation.
Wow.
And this facility is one of the referral lab facilities around. So we have the peripheral lab facilities bringing their samples to be analyzed in this facility.
That's great.
Of which I think it's a good progress for the town itself. We also have a pharmacy inside, which is well stocked with drugs, and we assure our clients once they come, they are going to be satisfied with the type of drugs we give them. We also have other imaging investigations that we normally conduct in the facility. Of interest is the endoscopy.
Wow.
The endoscopy imaging modality, which is normally used to diagnose conditions in the alimentary canal, which we find it very useful in this time and era in terms of diagnosis.
That's nice.
Last but not least, we also offer antenatal clinics.
Now that's our interest.
Sawa, very good for asking me that. So in the antenatal clinic, we basically focus on the unborn child. And we also focus on the condition and the health of the mother. Because if the health of the mother is compromised, we are also going to compromise the health of the child.
Sure.
So there are several parameters that we normally check when you are doing the antenatal clinics. There's an investigation called antenatal profile. It includes of the basic parameters that will signify the mother's health. This one includes the hemoglobin level. We also check if there are any diseases, common diseases which can affect kids, diseases like syphilis. We also check if the mother is infected with HIV. We also confirm if we have basic infections such as urine tract infections, which can be treated.
I think one day we'll discuss the ANC profile.
Sure.
And see all those examinations, lab tests, and why.
Sure.
The why.
Sure.
So for now, let's talk about postpartum hemorrhage.
Okay.
Because I believe when you're managing this mother all through, you are managing to prevent such a complication.
Of course.
No, what is postpartum hemorrhage?
Postpartum hemorrhage is basically excessive bleeding after childbirth. And for postpartum hemorrhage, you can classify it in two ways.
Okay.
You normally have the early postpartum hemorrhage and the late postpartum hemorrhage. So for early postpartum hemorrhage, this is excessive bleeding during the first 24 hours after childbirth.
Okay.
Yeah. And for the late postpartum hemorrhage, this is anything occurring after the 24 hours, but before the end of the puerperium.
So it's possible?
Yeah, it's possible to have a late occurrence of the condition. Yeah. So also when I define postpartum hemorrhage, there are some parameters that one has to emphasize so that somebody can understand in terms of the definition.
Okay.
We have two ways of delivery. So the first delivery is the normal delivery, where somebody delivers through the birth canal.
Okay.
And we also have the other mode of delivery, which is via a surgical intervention, or what we call cesarean section, as my colleague is terming it as kupasuliwa. So when somebody delivers normally, there is the expected amount of blood that one is supposed to lose. So one is not supposed to lose more than half a liter of blood. So if you have a mother after delivery losing more than half a liter of blood, then we can term that as postpartum hemorrhage.
Because it's possible to measure how much she has bled.
Because it's possible to measure, because for the placenta alone, there's an amount of blood that you are expected to lose. But also, once you've lost, using the sterile gauzes that are used, probably wipe. Maybe if one is fully soaked, it can be estimated. It has a rough estimate. So one can roughly estimate and see if the mother has lost blood. Yeah. And then the other mode of delivery, which is the cesarean section. This is when the mother will lose more than 1 liter, and that one actually can be classified and it can be quantified, because we have a sucker machine when you're doing the operation, and we also have the sterile gauzes which you use to wipe the excessive blood. So using that, you can accurately quantify the amount of loss
and diagnose
postpartum hemorrhage, and which will need immediate intervention. Yeah.
Now, could we please discuss the causes?
Okay.
What are the causes of postpartum hemorrhage?
Postpartum hemorrhage. So there are several causes of postpartum hemorrhage, and I think when we were doing our undergraduate studies, we tried to list them down, and we realized the list was becoming endless. We couldn't fully exhaust because we have a couple of causes. But we came up with a way of remembering all these causes, and we classified them depending on where the bleeding is occurring and what type of bleeding is occurring. We normally simplify them and say we have the 4 T's. Yeah?
Letter T.
Yeah, the letter T.
Okay.
So we have the big letter T and just put a prefix 4 there, and I think you'll have solved all the problems.
Good. Tell us about it.
For letter T, we have the first T standing for tone. For tone. And then we have the second T standing for tissue.
Muscle tone.
Yeah, the muscle tone.
Okay, good.
The muscle tone. And then the other T stands for tissue.
Tissue.
Now these are the surrounding structures. Surrounding structures which could be involved in childbirth. And then you also have the other T, which stands for thrombin. Yeah, thrombin is an element which is used in clotting. So any mother who has clotting issues or issues which are going to affect her clotting, then you can have this mother having excessive bleeding. And then last but not least, we have T standing for tear.
Okay. Daktari, shikilia hapo. When we come back, we'll talk about the 4 T's in details. Kindly to contact us, please use the number on your screen for any question, for any comment, for even appreciation. Keep with us. We'll be back. Back to our postpartum hemorrhage discussion. Daktari, can we please talk about now the 4 T's?
The 4 T's.
Yeah.
So let me elaborate about the 4 T's. So let me start with the most prevalent T, which is tone. So when I say tone, this one means the ability of a muscle to contract. The ability of a muscle to reduce in terms of size. So you remember during before the child was born, our uterus was greatly enlarged.
Yeah, it was.
It was greatly enlarged. And during childbirth, there is a hormone called oxytocin which is produced naturally, and it normally helps to augment the process of labor by making the uterus to contract.
When you say augment, you mean to accelerate?
Yeah, to accelerate.
Okay, good.
Yeah, to actually potentiate the function.
Okay.
Yeah. So after childbirth, it is expected, but it's expected that the natural oxytocin with the oxytocin which is also administered in hospital to assist our uterus to contract fully, so that at least the bleeders which exist where the placenta was attaching will contract enough to prevent excessive bleeding.
Sure.
But you have the factors which can contribute to what I can call atony of the uterus. So one of the factors which will contribute to atony is when you have multiple pregnancy. When I say multiple pregnancy, I mean pregnancy of more than one fetuses.
Twins,
so
triplets.
Triplets. So you'll have a massive enlargement of the uterus.
Okay.
So when the uterus is contracting, it might not contract to the desired levels. So you might have the mother losing excessive blood.
Because it was also excessively large.
Excessively large.
We understand now.
Yeah, you understand now.
Yeah.
And then you also have other factors when you have a big baby. When I say a big baby is any neonate who's born with more than 4 kilograms.
Okay.
Also, that one is going to greatly
excessively
enlarge
the uterus.
Yeah, the uterus. So when we expect the uterus to contract, it's not going to contract to our desired levels. So anything which is going to affect contractility of the uterus is going to make the uterus to lose blood excessively. And if the mom is going to lose blood excessively, then we are going to end up with postpartum hemorrhage. Now for the other T, which is tear.
Tear.
Yeah. So during childbirth, we have several structures, surrounding structures, which are involved when a child is being expelled out from the uterus. So all the way from the uterus, we have our open cervix, which opens serially and slowly until it's fully dilated to allow the head and the shoulders and the rest of the part of the body of the feet of the newborn baby to come out.
To be born.
Yeah. After the cervix, we have now the birth canal. And the birth canal has walls surrounding it, and the walls are well vascularized. When I say well vascularized, they are well supplied with blood vessels. So once you have this passage of the fetus from the uterus all the way to the birth canal, you can have injury of the surrounding structures or the adjacent structures. So any tear which is going to involve a large blood vessel and which is a potential cause of a bleeder there is going to result in postpartum hemorrhage.
And
so,
it happens?
Yeah, it happens a lot.
Okay.
So here I'm talking about cervical tear. I'm talking about tear of the perineal muscles because these are adjacent surrounding structures which might be involved during childbirth, which they might be damaged or traumatized during childbirth, which can also contribute to the excessive bleeding. And then the other T is tissue. Tissue. Now for the tissue part, immediately the child is born, the midwives wait for some few minutes and they try to deliver the so-called placenta. The so-called placenta. So the placenta was well attached to the uterus. So they are going to give the oxytocin to try and make the uterus contract and to make the placenta separate from the uterus.
Because it's supposed to be, the placenta is supposed to be born immediately after the baby is born.
Yeah, it's supposed to be expelled immediately after the baby is born. Because remember, this is what was maintaining the baby in the uterus. Now the baby doesn't require it. The baby is in the natural environment, so it needs to be expelled. So we have conditions where we can have complete expulsion of the placenta. So we have remaining products of conception. So these remaining products of conception can also be a great contributor of excessive bleeding.
Okay.
Yeah, and of which if it's noted, it needs to be intervened immediately so that we prevent excessive bleeding. So last but not least, we have now the thrombin, the last T, which is thrombin. So when I say thrombin, let us just concentrate and maybe imagine anybody who has any bleeding disorder. Yeah, because thrombin is one of the factors produced by blood to help us clot our blood. So anybody who has any bleeding disorders, you name them. The person could be having maybe low platelets. The person could be having some form of coagulopathies, which make them have an excessive, prolonged bleeding time. So when you have such conditions,
the specific time a person should bleed.
Yeah, there's actually a specific time a person should bleed.
Okay.
This one is normally between 2 to around 5 to 6 minutes. So you have people who can even bleed up to 13 minutes and there's no clotting occurring. Okay. Yeah, so you have people who cannot form clots easier. So they are more predisposed to bleed excessively and thus resulting in postpartum hemorrhage.
That is very good. Now, is it possible as a doctor to tell that this mother is at risk of postpartum hemorrhage?
Okay, thank you, Anne, for that question. So we have risk factors which can predispose us to postpartum hemorrhage. So one of the most important and the most prevalent factor is anemia. So anemia basically means you have a low hemoglobin level. As we all know, pregnancy is a physiological state, and for any physiological state, you'll have the body requiring more blood than ever. So the physiological state here is because we have an unborn fetus which fully depends on the mother in terms of growth and development. So the mother is going to require more hemoglobin.
Sure.
So as a result, you'll have his blood being diluted because of that. And then the end result is they are going to end up with low hemoglobin. So mothers who are anemic, they wouldn't really fit on the criteria of losing the half a liter or 1 liter, as we've said.
Yeah.
You'll even realize they've even lost half that amount, but they still show signs of postpartum hemorrhage. So it's postpartum hemorrhage per se also depends on the acumen of the clinician. The clinician should be quick and able to realize that the mom is decompensating and the mom needs to be resuscitated as early as possible. Now the other factors, these are just factors which will now affect our 40s. So as I say, anything which is going to affect tone. So if you have multiple pregnancy, if you have a big baby, if you have the hypertension induced in pregnancy, also these factors contribute and they increase the risk of mothers getting to postpartum hemorrhage.
Thank you very much, Doctor, for telling us this. We need to go for a break, and when we come back, I think you'll tell us about any interventions that you do, either during pregnancy, during delivery, or even within the 6 weeks. As you told us that postpartum hemorrhage can occur 24 hours to 6 weeks. You told us it's the late postpartum hemorrhage. Now let's go for a break, and when we come back, we will know the interventions that are done. Welcome back to our discussion, and if you've just joined us, we are discussing postpartum hemorrhage. This is the excessive bleeding after a mother delivers. Back to our discussion, Daktari.
Yes.
Could you please tell us if there are any interventions you do as the medical team? Because I believe you don't work alone as a doctor.
Yeah.
You have the lab people, you have the clinicians, you have the midwives who are very key in delivery. Are there interventions that you do, maybe right from this time a mother is pregnant, during labor, and after?
Yeah. Yeah, we normally have interventions, and we said anybody who has excessive bleeding, that's an emergency, and you need to resuscitate and immediately act upon that patient. So in terms of intervention, I'm going to approach on the intervention systematically.
Thank you.
Depending on the 40s which I explained, because you're going to intervene.
That's our baseline.
Yeah, that's our baseline.
Good.
You're going to intervene according to the cause of the postpartum hemorrhage. So, but the first resuscitative measure is to try and make sure that our patient does not go into shock, because as we all know, excessive bleeding can lead into shock. So the main
and in this case we are talking about a mother who has just delivered.
Exactly. A mother who's delivered, a mother who has a newly born child who is fully dependent on the mother. So we have to strive all the way we make the mom to survive. Sure. So the main resuscitative intervention that one has to do, you have to find an IV access.
By IV, you mean?
A cannula, you have to fix a cannula intravenously.
Ile sindano ya hapa.
Your sindano ya hapa. And it has to be large enough to allow transfusion of blood, because remember, we've lost blood. So we need to transfuse blood so that at least we can make sure that the circulation system of the mother is well maintained. So after introducing that cannula, you have to withdraw a small amount of blood so that you can send the blood to the lab, so that you can have a blood grouping and cross match of the sample. Okay. So that at least we can get
matching blood.
The matching blood. Okay, good. We can get the matching blood. As you're doing that, remember that your blood volume is lost. So you need to maintain the body with a substantial amount of volume as you wait for your blood. So you need to infuse intravenous fluids.
By infusion you mean
Yo,
kuwekwa maji.
Kuwekwa maji.
Ndio hiyo.
So you need to really maintain your circulation. So you really need to aggressively infuse so that at least you make sure the blood pressure does not go low, because we all know excessive bleeding is going to reduce our blood pressure. And once our blood pressure is reduced, we are not assured if you are going to fully perfuse our vital organs. When I say fully perfuse, we are not, the vital organs will be compromised of blood supply.
By vital organs we mean the heart,
the
lungs, the kidneys,
and
the brain.
Yeah. So the vital organs necessarily mean organs which maintain someone's life. So we have to make sure that these organs are well perfused.
Good.
So we have to maintain the pressure as we wait for the blood. So once we get the blood,
and that's why we are giving the fluids.
Yeah, that's why we are giving the fluids only as a resuscitative measure as we wait for blood transfusion.
I understand now.
So once we get the blood, during that period, we should try and ascertain the cause of the bleeding. So from the cause of the bleeding, that's where you are going to know in what stage and how are we going to intervene. So if I can start with the 40s, if the problem is the uterine atony, if the problem is our uterus is not well contracted, then we have medication agents that can be used to try and help our uterus to contract. So one of the commonly used medication is oxytocin, mainly known as syntocinon in a hospital setup. This one is used commonly to stop excessive bleeding in such a way it encourages the uterus now to contract.
By contracting we mean reducing in size. Reducing in size. So we have we also have another drug that we call misoprostol. The trade name is called Cytotec. Good.
Yeah. So this is also a very effective drug which helps us reduce the size of the uterus to desired levels to help it not bleed further. Then we can go to the other T. Though we also have other medications that can be used, but those ones are normally used wide in theater. I'm just mentioning drugs which can be used basically in a setup where we don't have.
This is a health center, this is a district hospital.
Dispensary, district hospital. Yeah. And then you can also go to the other T, which is tissue. So sometimes during delivery, after delivery of the child, there is the delivery of the placenta. So assuming the placenta was not or was incompletely delivered. Imekwama. So it's a clinician needs to manually remove, or a midwife needs to manually remove the placenta.
Must be very painful.
Yeah, so as to stop bleeding. So most of the time, during that time, you normally assess. It could be painful. Sometimes it couldn't be painful because the mom has just given birth. The mom was experiencing pain. So it's actually a relief for the mom. So you just find you only need an immediate scoop to remove the remaining chunk. But if you realize that your mom is feeling pain, then you have to organize for theater services so that you can take in the mom and remove the placenta. Because remember, if you transfuse blood and you've not addressed the underlying cause, it's like
it's useless.
Yeah, it wouldn't confer any benefit. It's like you're trying to fill in a tank which has a hole somewhere.
And a big hole for this
a big hole. So you're going to lose your blood. So you need to also address the underlying cause. Now on the other main common cause is tears. So the main tear that we normally experience is cervical tear, and one of the causes of cervical tear is precipitate labor. So when I say precipitate labor, there is a way the cervix is supported. The head is exerting pressure on the cervix, but you have mothers who have their cervix enlarging
very
abnormally and very fast. The other commonly tears which we normally experience in hospital, we have now the perineal tear. So the female external organs are normally surrounded by the perineal muscles, which during childbirth might be involved. And when they tear, they have good blood supply, and the mother can actually excessively bleed.
Thank you very much, Daktari. I tell you, we have learnt a lot. But just before we end our show today, I would want you to look at that camera and please tell us the importance of hospital delivery.
Okay, and thank you for giving me that opportunity. So the importance of hospital delivery as opposed to home delivery. Hospital delivery has an advantage in that it has qualified personnel, it has equipped laboratories, it also has good equipment and facilities around. So most of maternal morbidity and mortality can be addressed comfortably and professionally in a hospital setup as opposed to home delivery. So this is just a way of encouraging our mothers to deliver in hospitals. Thank you.
Thank you very much, Daktari. It was a pleasure having you in our show.
Okay.
May God bless you so much. From us here in Golden Minute Show, it's Shalom. Until we meet again, I remain your show host, Anbi, as we continue fighting against maternal, fetal, and neonatal mortality. Bye.